Undergoing fertility treatment is quite possibly one of the most emotionally challenging periods in a patient's life. Choosing which treatment centre to support your hopes for parenthood is incredibly important, not only for increasing your chances of success, but also for the support and future pathways they will offer if your fertility treatment fails. The Oxford Fertility Unit and its state-of-the-art laboratory is motivated to make this life-changing journey as simple and stress-free as possible. Our aim is to achieve the best possible outcome for every person that seeks our help. This film is intended as an introduction to us, our work, and the treatment paths our patients are likely to encounter. Whilst it can't answer every question you may have, we hope it will act as a stepping stone on this important journey, one we hope we can share with you.
One of the largest fertility units in the UK, and we generally are doing over 2,000 fresh IVF cycles per year, in addition to all of the other treatments. We have around about 2,000 new referrals per year. So the OFU is a private unit, but over half of the patients treated here are actually funded by the NHS. The senior staff in the unit are employed by the University of Oxford, and we have very close affiliations with both the university and also the Radcliffe Hospital.
We are one of the premier fertility clinics within the UK. We, both in terms of the numbers of patients that we see, the technologies and techniques that we have on offer, and our success rates.
A lot of the staff here have worked here for a number of years, so really experienced in the field. Consultants, though, are involved at every level, and you can expect that the staff are going to treat you with respect and dignity and listen to your individual needs.
So within OFU we have around 70 staff who are split between the medical, nursing, administration and also the laboratory mainly. But we also have a number of satellite units, and each unit will have its own complement of staff.
We are in a state-of-the-art purpose-built building, and we offer a very high level of care and individualised care to patients.
The team are really committed to changing people's lives forever. All the nursing team here would say we were incredibly privileged that couples allow us to become involved in what is the most intimate part of their relationship. You know, it's an amazing job to create life.
Which one of the fertility treatments a patient requires is very much dependent on the detailed consultation and the eventual diagnosis of their fertility problem, but many of the processes and procedures overlap. IVF is the most common treatment, and we will focus on this before returning later to the other treatments and how they subtly vary from IVF.
So IVF, or in vitro fertilisation, is a treatment which has been around since the 1970s, and over that time there's been year-on-year refinements of the technique. Essentially what it involves is the woman taking stimulation, daily stimulation by injection, to stimulate her ovaries for around about 2 weeks. We then take the eggs from her ovaries and we fertilise them in the laboratory with sperm to make embryos. We then grow the embryos on in incubators for a few days, between 2 and 5 days, and once we see that there's 1 or 2 best quality embryos to put back, we then replace those using an embryo transfer procedure. That essentially is an IVF cycle.
1 in 6 couples has problems conceiving, and the Oxford Fertility Unit, or OFU, receives over 2,000 referrals per year from across the UK. These referrals come from GPs and private practitioners, and the first contact a couple has with the OFU is a face-to-face meeting.
Initially, you'll see a doctor here to discuss what treatment options are going to be best for you. If it's IVF, whether it's a more straightforward treatment like intrauterine insemination. Having done that, if IVF is deemed to be the most appropriate form of treatment, there are a few tests and investigations that we're going to need to do. So we'll need to ensure that the quality of the sperm is good enough for treatment. There are a range of hormone blood tests that will be required. Some of these are done at specific times of your cycle, so you may need to go to your GP and have those done in the first half of your cycle. You will then be seen for what we call a nurse planning appointment, and we will go through all the consent forms with you that are required to ensure that you are fully informed about your treatment. We will run through the risks and side effects of treatment and actually plan when you're going to start. As part of that, we'll do a vaginal ultrasound scan so we can assess your uterus and your ovaries, how efficiently we think they're going to function, and answer any of the questions that you may have for your treatment cycle.
An IVF cycle is essentially split into 4 distinct sections. First, stimulation. Then, fertilization. Next comes the embryo transfer. And then there's the aftercare. The first phase of IVF is where the female patient's ovaries, through careful hormone ingestion, are encouraged to stop ovulating and then stimulated to produce multiple eggs. This delicate and critical process is monitored so the consultants know when the eggs are perfectly mature and ready for the final part of this preliminary phase, which is egg collection.
So if a woman's going to have long protocol IVF, that means we need to downregulate the hormones which drive her ovaries on. And the way that we do that is we use a drug called an agonist. And this agonist drug can either be given by a sniffer or a daily injection. And after about 2 to 3 weeks, it will have switched off the hormones that come from the pituitary, which is a gland in the head. And therefore, because those hormones are switched off, the ovaries will be switched off. We can then move on to the next stage of her IVF cycle.
Once your hormones are at baseline and we're happy that everything is ready for you to start your stimulation, we will actually teach you how to inject the drugs you're going to need to stimulate your ovary. That dose of drug has been prescribed by the consultants and is based on your age, your weight, your height, your own levels of follicle stimulating hormone, and how your ovaries appeared on your baseline scan, so how many little follicles there were on your ovary.
If she's had any fertility treatments beforehand, then we'll also look at the outcome of those drug treatments to see how she responded to those drugs. And we therefore choose a starting dose of stimulation which is most appropriate just to her. When she comes in for her monitoring scans, either in Oxford or in the satellites, then again we will review the dose she's on, and a consultant will take a decision on whether to alter the dose of her stimulation as she goes along. Because what we're aiming for is not over or under stimulation, it's a sort of a healthy, happy middle ground.
Most people will inject for a minimum of 8 days before coming for their first scan. And your first scan will either be on a Wednesday or a Friday. At your scan appointment, we're looking to see how your ovaries have responded to treatment. So we will again do a vaginal ultrasound scan. We will measure the thickness of your endometrium, because now it should be getting thicker. We will measure the number of follicles on each ovary and measure the size. And we will also do a blood test to check your hormone levels. So we're looking at your estradiol levels. As your egg develops within each follicle, they produce estrogen, and we're going to measure that to give us another indication of how mature the eggs are in the follicles.
So many patients, many women are understandably very worried about the egg collection. They're worried, is it going to be very painful? Are they going to be awake during the procedure? Fortunately, we've arranged that there's a consultant anaesthetist present for all of the egg collections. And on the day of the egg collection, The patient, usually with her partner, will come to the Oxford Fertility Unit. They'll be given a private room, and then the doctor undertaking the procedure and the nurse involved will come and introduce themselves, explain the process, and ask the woman to sign a consent form so that we can then move on to the actual egg collection procedure. She's then taken through to the egg collection room, where again the anaesthetist will say hello, take a quick medical history to make sure everything's fine. We'll have looked through the notes, and then we'll put a drip into the woman's hand or arm to give some sedation through. The embryologist will check the patient's name and details. The anaesthetic will then be given. Once the woman is sleepy and is not aware what's happening, then from our point of view, from the doctor's point of view, we'll then move on to the egg collection procedure. A scan probe is put into the vagina and we look at the stimulated ovaries on the screen. And then we pass a needle through into each of the follicles and drain the fluid out. And then the fluid from those follicles is passed through to the lab. The procedure takes about 10 to 20 minutes usually. The patient then goes through to a recovery area where a specialised recovery nurse will ensure that will monitor all their vital signs. They may be there for another 15-20 minutes or so before going back through to the initial private room that they first went to. During the time that the egg collection is going, if there's a male partner there, then often he'll be asked to produce a fresh sample, unless there's frozen sperm that's being used.
After the eggs are collected in theatre, they're placed in incubators in the lab. This is where the next important step in the IVF treatment takes place: fertilisation and embryo selection.
Fertilisation takes place on the same day as the egg collection. Once we have the eggs, those eggs are put into an incubator, which is at body temperature, so 37 degrees centigrade. The process actually takes the live sperm away from the dead sperm. So again, it mimics what would happen in the body in that the live sperm will swim to the site of the egg. So what we're aiming for in that preparation process is to have a nice live preparation of sperm that we can then use to fertilise the eggs a little bit later that same day. And that is where we ensure that the eggs and the sperm have actually met. So we put them together in the same dish. There's about 100,000 sperm put with each egg. Hopefully one of those should then be able to fertilise the egg overnight.
Fertilisation is successful in the vast majority of cases, with only 2% of patients experiencing total failure. The development of the various embryos is closely followed by the embryologists before the next step of IVF, which is embryo transfer.
Once we know we have fertilisation, at that point we have an embryo. We will obviously let the couple know how many eggs have fertilised, and at that point we can then set them up for their embryo transfer.
We then culture the embryos on for a few days. And what we're trying to do is to push the embryos on until we really see which are the best ones to go back. And that normally lasts for 2, 3 or 5 days. Once we see there are sufficient embryos of good enough quality to go back, then we'll ask the woman to come in for an embryo transfer. Usually the partner comes along as well and is in the room for the embryo transfer, we call it an ET. No anaesthetic is required for that at all. It's really a bit like having a smear test. And during an embryo transfer, what we do is we put a speculum in the vagina to clearly look at the cervix. The woman needs to have a full bladder for the embryo transfer procedure because we use an abdominal scan probe to look through her bladder, to look at the womb, to help us make sure we're doing the embryo transfer into the optimal place within the womb. The lab will then come through, introduce themselves, give the patients an update as to the quality and the number of their embryos, and then we'll be putting very often the best single embryo back, but sometimes 2 embryos back into the womb, using a syringe and a catheter through the neck of the womb.
We can actually only see on the ultrasound scan the tiny drop of culture media that surrounds the embryo. So we pass the catheter back to the lab and they will flush it through and confirm that the embryo has actually left the catheter and it's safely in your uterus. We will then talk you through the next 2 weeks while you wait for pregnancy tests, which is obviously quite a worrying time for you. But we'll talk you through the things that we think that you can do and you can't do.
As soon as we finish the embryo transfer procedure, then the woman can get up and head off home. But we'll have sent her home with a pregnancy testing kit, a urine pregnancy testing kit, and also very clear instructions on what to do next. And the pregnancy test is done about 16 days after the egg collection. And we'll ask the woman to phone in either to here or the satellite unit, depending on where she's had treatment, with the result of her pregnancy test. If, fingers crossed, she's pregnant, then a pregnancy scan will be arranged a few weeks later. If she's not pregnant, then we'll have a discussion with her over the phone about possible next steps. And it may be that the patient or the couple want to return to here or a satellite unit for a consultation with the medical or nursing team, or to see the counsellor, for instance.
OFU provides counselling which is available before, during and after treatment. We are very much geared to look after patients for whom IVF fails, as well as for those for whom it succeeds. Even with the onset of pregnancy, our commitment and involvement does not diminish.
There are risks associated with any pregnancy. 1 in 5 pregnancies potentially will end in miscarriage, and that doesn't matter whether it's a pregnancy conceived using IVF or a natural conception. If you're lucky enough to have a positive pregnancy test, then we will need to speak to you and arrange a early pregnancy scan. We normally scan you about 3 weeks after you've telephoned with your pregnancy test. This is when you're approximately 7 weeks pregnant, and we can then be assured of seeing a fetal heart and a gestation sac. Unfortunately, not all positive pregnancy tests will continue on to a successful healthy baby, and there is a small risk that you may have a miscarriage between your pregnancy test and your first scan. If everything, however, is all right with your scan when we see you, we will then do your paperwork and discharge you to your GP, letting you know the date your baby is due.
As we mentioned before, IVF is not the only fertility treatment available. In this final section, we will briefly discuss other treatments and the cases for which these might be more suitable and how the treatment varies from IVF. ICSI is where there are not enough strong mobile sperm, and so sperm are manually selected and injected into the egg. This occurs during the fertilization phase. All other parts of the treatment are the same as IVF. In vitro maturation, or IVM, is where eggs are removed from unstimulated ovaries and are matured in the laboratory for 24 hours before being inseminated with sperm. This treatment is an alternative to IVF for women who have polycystic ovaries.
So we were the first clinic in the country to be given a licence to perform IVM. During IVM, there's no ovarian stimulation at all, and we go straight to the egg collection. That means, though, that the eggs we get from her are immature. We then give the drugs to the eggs in the laboratory for a day or two to hopefully mature the eggs in the laboratory. Once the eggs are mature, we then fertilise them using a procedure called ICSI, or injecting sperm into the eggs. And we then grow the embryos on, and then it's the same as any other IVF cycle.
Surgical sperm retrieval, or SSR, is a method used to obtain sperm directly from the testes. It's used for men where sperm have not been recovered from the ejaculate, or who have had failed vasectomy reversal. Following sedation and a local anaesthetic, a fine needle is then used to extract small pieces of tissue directly from the site of the sperm production. If sperm is found, it can be frozen for use in an IVF cycle later. Because the number of sperm aspirated is small and the motility is reduced, ICSI is required to achieve fertilization. Egg and sperm donation is a very important part of the OFU's work. Eggs from a donor can be used in cases where women have suffered an early menopause or have hereditary genetic disorders. There's no need to go through the stimulation phase of the IVF cycle. Legally, offspring can trace donors on reaching 18. This is also the case for offspring from sperm donation.
Donor sperm insemination is a treatment which has been around for a very, very long time, and it's essentially for couples where the man is producing no sperm, or there may be severe abnormalities with the sperm, or for same-sex female couples or single women. And for donor insemination or DI treatment, what we do is we have a number of sperm donors. Where after matching with a potential sperm donor, we then thaw out some of that sperm and we inject it into the woman's womb at the right time around ovulation, and there's various monitoring that's used to make sure it's at the right time. Obviously, to get pregnant with DI treatment, the woman needs to have at least one open fallopian tube. Alternatively, we can use donor sperm during an IVF cycle. The success rates with donor sperm during an IVF cycle are significantly higher than just using straight donor insemination, so that may be the best way forward for some people.
Commonly, in an IVF cycle, we end up with more than one good embryo due to a number of eggs fertilizing. As we will transfer just 1 or 2 embryos into the uterus, we can freeze and store any remaining good embryos for the patient. It means that should they decide on having IVF again in future, the stimulation and egg collection phase can be removed, relieving stress, financial pressure and possible medical complication.
The Oxford Fertility Unit is certainly one of the UK's, if not Europe's, or even the world's, top fertility units. We have a long history of successful fertility treatments, but also importantly, we're very research focused. And I think the research element to what we do keeps us at the cutting edge. We've been the first in the UK to introduce a number of techniques such as IVM, so in vitro maturation, and also some of the genetic testing of embryo techniques, the PGD and PGS. Patients coming to Oxford Fertility Unit can be assured of the best quality care in the best surroundings using well-trained staff and top quality equipment. All of that leads on to very high success rates and really a great standard of care. The high points of the job are seeing people come in who've been desperate for a family for many, many years, and helping them, as part of obviously the whole team, achieve their dream of a family. Having said that, clearly for a proportion of people, their dream doesn't come true, and the treatment, for whatever reason, may not work. And in fact, some of the nicest, most heartwarming letters that we actually get, are from couples who've been unsuccessful with their treatment, but feel that they've really given it the best shot in the best surroundings with the best team, and they feel they couldn't have done any better.
The Oxford Fertility Unit is part of the Academic Reproductive Partnership, using research to push forward reproductive medicine and success rates.